Good morning, one and all. I'm Dr. Reena Singh. Today I'm going to speak about refractive rehabilitation of keratoconus patient with cataract with monofocal IOL and RGP contact lenses. So as we all know, before any surgery in keratoconus, the stability of the disease should be assessed as surgical intervention has been documented to cause progression in these cases. There are multiple sources of error in precise determination of IOL in these cases. So to improve outcome, there must be some addition other than IOLs sometime can be planned. So why toric IOLs are unpredictable and challenging in keratoconus cases? So there are various biometry challenges. Some are like refractive index error in keratoconus. Keratoconus has altered ratio of anterior and posterior corneal curvature. So standard refractive index 1.3375 is erroneous in these cases. There can be some instrumental error because of the pupillary offset. As the radius of curvature reduces, the effect of K error increases in these cases. There are difficulty in exact formula used in these cases, as there can be unpredictable effective lens positioning in these cases because of steep cornea, higher axial length, and deep anterior chamber depth. There are some tear film irregularity which also can affect the repeatability and reliability of K reading. So why RGP contact lenses in these cases should be preferred? As we all know, RGP contact lens acts as a smooth surface along with tear film contact lens, and it helps to reduce the irregularity of cornea. The refractive error and aberration in keratoconus is not always fixed or regular. It can be mixed, irregular, and high in quantity. RGP has advantage here over IOS that it acts as a pseudo-regular cornea by acting together with tear film lens and compensate for regularity of the corneal surface. It is available in multiple design and options to compensate for irregular cornea. Here there are some examples of RGP lenses that we can use in different kind of astigmatism and irregular astigmatism. The benefit of RGP lenses, the modern RGP lenses are very comfortable and easy to fit in extremely irregular cornea due to possible design modification that helps them to stay more securely on eye during sports and other activities, allow oxygen to pass directly through contact lens, retain shape even while blinking, has large coverage and choices, durability and deposit resistance also, extremely durable with little care, so RGP can last years, they can be less expensive in long term. The only downside is adaptation required to RGP in some cases, especially in those patients who is not using RGP before surgery. Why not toric IOL in challenging keratoconus cases? Toric IOL requisite in any case, including keratoconus, is detection of abnormal corneal shape, evaluation of corneal cylinder, evaluation of corneal irregular astigmatism, and evaluation of corneal spherical aberration. Here we have challenges in keratoconus that includes in keratoconus, there is high chances of irregular astigmatism. Regular astigmatism can be present, but determining the ideal toricity is ambiguous due to vertex shift or pupillary offset. Stability of astigmatism is also a problem. There are conventional method of keratometric measurement, which is not very good in keratoconus because of refractive index changes and negligence of posterior corneal astigmatism. Newer modalities does help in negating these 2 points, but they are more realistic in keratometric measurement, but will deviate from normal SIMK value, so they cannot be used in conventional IOL formulas. Is the true corneal refractive power or equivalent refractive power is an answer? Actually, it is not, especially in advanced keratoconus. Pupillary offset is there very significant in keratoconus cases, mostly due to Y offset, but offset values of both X and Y correlate significantly with the keratoconus stages. So mean arithmetic value and power vector for total corneal refractive power within 2 to 5 millimeter zone in various studies, it is found that it is very variable. Mean K astigmatism different at pupil and vertex. If manifest pupil estimation goes wrong, leave aside the axis changes, magnitude changes itself will cause huge surprise in IOL power, especially in toric. So IOL power barometry, another challenge is axial length estimation. IOL formula also has limitation in keratoconus cases because all these formula has been formulated for normal eyes, and still there is no comprehensive consensus about which formula is best even in mild keratoconus, so larger studies still required. Post-operative concerns are also there. The prediction of positive error after 1 month is highly low or almost zero in higher stages of keratoconus. Post-operative, another concern is rotational stability and progression of the disease. Rotation of toric IOL greatly depends on capsular bag size, axial length, and associated myopia, which is theoretically high in every keratoconus case. So coming to the conclusion, the toric IOL can be an option in stage or mild cases, but concern that cannot be compromised on the name of one-time surgical solution or biometric challenges, questionable stability of disease and IOL rotation. So I presume that RGP contact lens after targeting hyperopia in final IOL powers can be put on RGP contact lens because it compensates for corneal irregularity with tear lens, can be readjusted for IOL surprises or progression of ectasia, has wider range and design modification for irregular advanced cases of keratoconus. It is time tested, excellent reversible solution. Even in post-operative progressive cases, it's a solution with satisfaction. So toric IOL should not be put or considered in cases where patient with progressive disease, difficult refraction, or in whom there is a high difference between preoperative RGP contact lens corrected visual acuity and spectacle corrected visual acuity. So I conclude RGP contact lenses should be considered in high toricity and higher stages of keratoconus. Thank you.